It's Monday and time for the Back to Business podcast, featuring Calgary's industry leaders. Welcome today's show host, Kim Hayden.
Are you or somebody that you know facing the challenge of aging, chronic illness, or even just recovery from surgery, and you really don't want the ER to be your mainstay, your go-to? Well, there are solutions out there. Sometimes we just don't hear about them until once we've dealt with the challenges that we face. But our guest today, Dr. Charles Wong, is here to walk us through how we can have a home-free, carefree space that gives us dignity and our ability to take care of ourselves. I'm excited for this conversation because, face it, we're all going to face it at one point in time. But first, our land acknowledgement. We here at the Calgary Petroleum Club, in the spirit of reconciliation, honor and acknowledge that the land on which we learn, work, and live is Treaty 7 region of southern Alberta. This place is the traditional homeland for the First Nations and Métis peoples, and today we all are part of this treaty land. Okay, so we're going to start this a little formal. Welcome to the show, Dr. Charles Wong. And then we're just going to be going right into Charles. How are you doing today?
I'm doing great, thank you. How are you?
I'm doing awesome. I'm doing better now that you're here.
Thanks for having me.
I'm always interested in kind of taking a closer look at healthcare versus sick care versus home care. How do we start bringing so people can stay where, you know, they're comfortable, they have their things, and we can support them. Mm-hmm. And I'm really glad we're having this conversation because this touches everyone. Mm-hmm. This touches everyone.
Absolutely, it does.
So let's dive in. Charles, you spent years in emergency medicine. And for those of you, I know the majority of you are listening to this, but if you go over to the CPC YouTube, you will see, come on, Charles, a decade in medicine. But yes, folks, he has done a decade in medicine. Tell us what inspired you to do home-free home care?
Yes, thank you for asking. My emergency medicine background, so I've been working here in Calgary since I finished my residency in 2016 and as an emergency room doctor at the Rocky View. And day after day, we'd be seeing patients who were having to recommend admission to the hospital, which we know in a large majority of cases leads to long-term hospital stays and then eventually placement, we call it, at a facility, against basically that patient's wishes. You know, patients will look me in the eyes every single time when I recommend admission saying, do I have to stay in the hospital? Can't I possibly go home? And unwillingly, I have to recommend yes from a medical perspective. And finally, that got to me. I started examining and looking at the reasons that were admitting patients to hospitals. And it turns out that a lot of it, if not a majority of the patients that we admit to hospitals, probably in the whole country, but certainly where I work at the Rocky View, has a lot, if not everything, to do with just the absence of proper home care.
Yes.
ADL, or activity of daily living support in the home. And the failure of that leads to patients having complications and then requiring, I'm doing it in quotes here, having to come into hospital when in fact, a lower cost and much better from the patient's point of view option at home would have been preferable. And so I came out to solve this problem with our company called HomeFree Homecare.
Well, and right now we're in the next 15 years for seniors. When we're looking at seniors, the next 15 years is going to be the highest impact we've seen on our medical infrastructure. Right. Mm-hmm. It's. I believe this is correct. I may be wrong. You'll know better than I. But it's said that the greatest need for medical care is in the last 2 years of your life.
Absolutely.
Is that correct?
Well, that's for sure. And if it's going to get worse in the next 15 years, I don't even want to know what that's going to look like. Because right now, and I still work in the ER, our system is like bursting at the seams. Everyone knows this. It's cracking in every direction possible, whether it's cancer care, surgery, mental health addictions. But hospital bed utilization, which is what we're talking about here, is one of the most severely impacted. Currently, 1 in 5 acute care beds in the country is currently occupied by a patient that is what they consider alternate level of care, or ALC. That means they actually have no acute care needs. They don't need to be in hospital, but they can't go home, and there's no long-term care beds for them. In other words, 20% of the acute care beds in the hospital are being used by people who shouldn't be there. And this is why this is such a pressing problem, not later, but right now, and it'll only get worse.
Okay. So let's break that down. So one of the things I could see being a challenge is when my mother had to have a knee replaced and then she fell, and my mother's quite large and in her 70s, so mobility is not the best for her even when she has working knees. There was an issue of being able to access the restroom. So, okay, so to get this 20% out of the hospital beds and in a place where, I don't know about you guys, but if I've got my blanket, my tea mug, I'm watching a movie on my couch, I feel a lot better than when I'm in a place that's foreign, smells funny, and is not nearly as comfortable. I mean, seriously, who wants to be in a hospital bed with the crappy pillows?
Oh my gosh, you're so right. And the kicker with this 20% is that the large majority of those people like detest being there, just as you say. And so was it your mom?
My mom.
Your mom.
Yeah.
Okay, I'm sorry to hear this experience, but it's something I keep hearing. Not being able to go to the washroom, in other words, not being able to meet her ADL, is an extremely common reason for being admitted to hospital. It is a problem that could be solved for a few $100 a day, if that, of customized, well-organized home care. But it's a problem that's otherwise being solved by a $2,000 per day hospital bed. So someone needing to help to go to the washroom is not a problem for the hospital system to take care of. And yet it's the only option our system is providing patients like your mom. And this is an everyday thing that I see in my ER practice.
So finding some solutions that way. So let's talk about the solutions that you are bringing to the market. Because I like I said, I believe that we have lived in North America. Because you don't see this in a lot of other developed cultures around the world. We have lived in a sick care space, and now we need to rethink what is healthcare. Healthcare to me means that you feel good about where you're at and your body's performing at the best it can, and that the community is supporting you, they're supporting you, but and it's not through just put them in a bed or give them another prescription or whatever. And folks, I'm not saying don't take your prescriptions. I'm saying you got to be so careful on this topic. I'm saying there's got to be a balance.
Totally. So what you've alluded to is the fact that community needs to chip in to help with their families. And almost universally, patients that we see admitted to the hospital, their families have been contributing. They've been contributing. They've sacrificed their work, their own physical health, their own mental health, sometimes at the expense of their kids and the other people that they need to look after. And so this is caregiver burnout. And this is also an epidemic that's a direct result of our inability to give patients the support they need at home in a publicly funded and organized way societally. And so the reason that home care is doable is because, actually, let me back it up. The reason that home care has not been done well so far is because we have not taken families and brought them into the equation as part of the solution. We've provided these kind of cookie cutter home care services, which what I call traditional home care, which is a one size fits all sort of thing. It doesn't take into consideration what you as a daughter do for a living. Like, for example, you may work from 8 a.m. to 4 p.m. Therefore, you need help in those specific hours. And home care will often only provide care in the opposite or something like that. And so this is where a better organization, a different way of doing home care is so necessary. And that's exactly what we're trying to do.
Amazing. Do you have a moment or a story? Because you're working at the hospital still and co-founding this initiative and getting it up off the ground and serving people. Like it's such a huge... who's taking care of you emotionally, mentally, physically through this journey?
Well, thank you for asking. I guess I would say I'm very lucky in the fact that I have, and maybe this is where I came up with HomeFree, which is that I have utilized people who are better than me to look after the aspects of the life that I need to offload off my plate in order to live my life in a more freeing way. So for example, I have folks that help me cut my lawn. Or help me to clean my gutters. And these are jobs that I could theoretically do, but I offload them in order to live, in my view, a freer life. And I keep using this word free because it's in the name of our company, HomeFree, we offer the same sort of opportunity to seniors or folks struggling with chronic disease, because a lot of folks struggle with the idea of getting help. And I have to remind them that I am a 37-year-old male, theoretically in the prime of my life, and I have quite a bit of help in order for me to live what I feel to be a free life. And so I offer that to families, which is, why don't we get you the help so you can do what you want to do?
You don't have to feel guilty. We're no longer our grandparents from the Depression where we must do everything, right? Because, we came through and, we have to do everything. We have to fix our own plumbing and we have to, do everything ourselves. Asking for the help. This burnout word is one that I keep hearing, unfortunately related to the medical industry, and it's a global epidemic. I would think that sometimes it's the stories or the successes that really help spur on and drive you forward. Can you share a story, a person, somebody that you've really impacted that you go, I'm on the right path. I need to do this.
Totally. I want to come back to that burnout if you have a moment later, because I applied it to families, but it equally applies to providers. And that's something we focus on in our company as well. But to answer your question, this is a very common story that I see playing out every day. And I can put different names to this, but I'll call this person Nancy. Nancy is a 90-year-old lady. She's accompanied by her daughter. Maybe her daughter's name is Karen, a common Gen X name that we see. And Karen's with her mom in hospital in a hallway because there's no beds or rooms for folks anymore, and is admitted to the hospital because she can't use the bathroom, which is one of the most common reasons we admit patients to the hospital. The ostensible reason for going into hospital is to strengthen her up so that she can use the bathroom on her own again, her so-called baseline. But guess what happens when you're in hospital? We all imagine this hospital to be some magical place that you get better. Nancy lies in a hospital bed 23 hours a day. She might get half an hour of help in the morning and maybe another half an hour of help in the evening, getting up with a physiotherapist who's run off her feet. This physiotherapist, that person's burning out. And so what happens when a frail person who's weak lies in a hospital bed in an unfamiliar place where they're getting poked and prodded on a regular basis, sharing a room with someone who's snoring? There's smells, as you pointed out earlier. Lights are always on. They actually get frailer.
Yep.
And so these people will often not get better, in fact, get worse. And then they become these ALC patients I mentioned earlier. They're waiting for a long-term care bed that doesn't exist yet, and they'll spend months and months waiting for a hospital bed in the hospital. These folks call us about once a week now, and we're in there the next day talking to the doctors, the physio, and the nurses at the bedside about what it would take to get Nancy home. Well, they'll explain to us, okay, well, Nancy can't use the washroom. Our physiotherapist is stretched. She's only getting once or twice a day for a few minutes a day of physio. She needs 6 times a day physiotherapy. And by the way, while she was here, we noticed she has a bladder infection, so she needs to finish this course of antibiotics. And we also noticed her blood counts were low. This needs to be checked next week. All this we can do in hospital. We say, as HomeFree, we say, okay, we hear you on the physiotherapy. We hear you on the needs to finish antibiotics. We hear you on the complete blood count that needs to be done next week. We can do all these things at home. And by the way, we can do it for 1/10 of the cost that you're doing it in the hospital, and we can start in 2 days. And so that's what we do. We literally figure out everything that's needed to go take someone's home, and we deliver to them in their own home where it's physically possible, and we can do a lot. And so every week we're taking home folks that have been in hospitals for weeks to months, and we bring them straight home. And the second they walk into their home, it's like a humongous weight has lifted.
Yes.
So, and they, you can imagine what happens next. They get better.
Yes.
We're providing them with 4 to 8 hours of care a day as opposed to the 1 hour a day they were getting in hospital. And we're doing so at a cost that's affordable to the vast majority of middle-class families easily, especially when you consider, and this is a really interesting point. Did you know that if you stay in hospital as an ALC patient, so if the doctor has determined that you're not there for any acute care needs anymore, you're just there for ADL supports, you have to pay out of pocket $67 a day, which is about $2,000 a month. So that is that is placed there as an incentive to get patients home for both the provider and the family's point of view, but it's also a huge financial burden. And so when we get patients home, they're paying less than half of that out of pocket. So they're actually saving money to go home and saving our system a hospital bed at the same time.
And why don't people know about this?
I know, right? It almost sounds like it's too good to be true. But it's not. We are literally doing this all the time, and people don't know about it because up until we started doing this last December, November, this didn't exist. And so we are getting the word out right here. We're telling as many doctors, clinics, and hospitals as we can. that this is what we're doing, and we're trying to build it out and scale it out. This is a new way of doing home care. We call it medically supervised home care. We coined the term, so it is new, but it's spreading rapidly.
Amazing. And I've heard, and what's interesting, I heard that there is a movement amongst nurses in the United States to exit hospitals and traditional care facilities. And they're looking on how they can do this because that's the same thing. It's about the system is about sick care. It's not about health care. I know what you're saying absolutely works. I personally, for those of you who don't know, I'm from the States, and I chose Canada in 1995 to immigrate here. It has been a phenomenal country. I am a 110% in support of our medical system and anything I can do to support, because I believe it's a human right. And I had a son in Kansas, and then I had a son in Toronto. Mm-hmm. And I will tell you the difference between the programs, the systems, and the placements. And Toronto actually does a few things better than we do here in Alberta. And I would love to see, and maybe they don't do it anymore. I don't know, because of the way of the system. But I remember that I got very, very sick post-second child. And I had mastitis that had gone through the entire body. And I was very, very, very sick. And this is in part due to a pre-existing condition. And I'm at home and I'm in tears. And day 3 of being at home with my baby, I called the hospital and I said, I can't take care of this baby. I don't know what to do. He won't nurse. I'm sick. I'm on the massive, I was on an antibiotic to eradicate every bit of yeast, everything from my system. And they sent a nurse out. I was in my pajamas in my home with my baby. And it was a defining moment in my experience within medical professionals. Having that person come to me and say, I see you, I want to support you, and I want to serve you so you get better. And it took a week of retraining this baby. And you know what? Not all babies know how to nurse. Retraining this baby, helping me get back on my feet. And so I really believe that we have to look at bringing back that home space, the doctor's visit. And I'm not saying call the doctor, 11 p.m. and, grab the bag and I'm going to come to the house like we see in movies in the 1950s. But to this day, that moment, that humane respect to me changed all of my beliefs. I already believed in medical for everyone, but having that person see me in my own home and doing the one thing that I felt that I was failing at, and having somebody who's 90 who's been able to go to the bathroom her entire life, and now she's failing at going to the bathroom, right? These are things that we feel like we should be able to do. I absolutely love it. Let's talk. You want to just circle back around to burnout. And this is the one thing that really worries me. And we are seeing greater and greater, especially since the pandemic.
Yes.
Let's talk about burnout and how those of us who have a care provider in our circle, how we can support that person.
Okay. Well, let me answer that in 2 parts then. So you brought up burnout. I mentioned that we're trying to cure burnout in families, and we're doing that by curing burnout in providers. And so one of the reasons that traditional home care, again, that's what we distinguish our medically supervised home care against, which is basically the everyday public home care that you get, is that is basically the definition of the home care market right now, which is that it's been a race to the bottom for the lowest cost volume product, which is fine if you're doing really simple stuff like catheter changes and wound care, like single one-off things that don't require a lot of, let's call it customization or individual attention, just rinse and repeat kind of stuff. But when it comes to complex stuff, like patients failing to live at home, it just doesn't work. It fails over and over and over again. And one of the reasons it fails is because the demands that are placed in front of the providers, really well-meaning, hardworking, caring people that went into care providing as a profession, they're being asked to do jobs that cannot be done in 5 or 10-minute chunks. And so they're going to a home to ostensibly help a person go to the bathroom, but then it turns out that they're in chronic pain, they're crying, they just got a cancer diagnosis, there's there's animal feces on the ground because they haven't been able to get up and clean their litter box for their cat. And so they're met with this overwhelming, like a tidal wave of problems as soon as they enter the home, and they're only enabled to do the slightest task in that home. So there's moral distress that comes out of that, where you're walking into homes all the time. And also, it's inescapable to spend more than 5 or 10 minutes with a person like that, because you're a human being interacting with another human being. So you end up spending 15 or 20 minutes trying to get the job done, and then you're late for your next appointment. Or, heaven forbid, and there's been exposés written about this that you can Google, like these companies will sometimes deliberately double book their employees to try to maximize their billings to the government payers. And so there's all these like systemic problems with the industry that burn out the caregivers, and none of them want to do this anymore. They do the worst possible job when they're doing it, not because they're bad people, because the system around them doesn't work. And so we do this differently at HomeFree. We make providers the core of our product, of the business, and we make sure that A, that are never double booked, but B, they're remunerated and supported properly for the complexity of the job that they're trying to accomplish. And that's not rocket science. It's paying people a living wage, which is almost unheard of in this industry. And it's also giving them the proper institutional support. So training to actually accomplish or to help solve the problems that they're seeing in the home, supervision from someone other than another overworked manager who's overseeing 200 cases, who doesn't have time to help the employees at the front lines work through the complex problems that they're seeing. And so when you do that, you help people thrive. And so how do you help, to answer your direct question, how do you help providers to thrive in their environment as care providers? Number one, I'd say, is look for providers, when we get into the costing of home care, I'll explain this, but you have choice when it comes to home care providers. You can ask your home care provider, when you're talking to the manager or the salesperson you're speaking to, do you guys provide a living wage to your care providers? How do you schedule your care providers? Do they get any sort of medical oversight or training? These are great questions that would challenge the people in management to consider what they're doing for their care workers. And then also, when it comes to public healthcare, and I'm a huge proponent of public healthcare. I work in a public healthcare setting in the hospital. Encourage your elected officials to fund public health care to the extent that's required. I mean, that's what we can do in a democratic society where we have shared resources, limited but shared resources, and also encourage them to devote those resources in a cost-effective way, which is what we're trying to do with home care as well. So why look after mom in a $2,000 a day home care bed, hospital bed, when we can do it for $200 a day at home?
Yeah, absolutely. Absolutely. Do the professionals, do they get more flexibility? So the professionals that are working, are they able to, because a lot of times I think that because our hospitals are running so thin, that they'll be at work and they go, oh, by the way, we need you to stay an extra 3 hours or something. By shifting into this, are they able to navigate? Because the reality is, I don't know if you have children, but you do. Two.
Yeah.
When somebody is in chronic pain, or somebody is been injured, or somebody has, God love my baby. She's at the hospital probably once every quarter for beta blockers because she has so many chronic issues with her back and such.
I see.
But when somebody's in pain, they forget that the person treating them also has a life. Also maybe the sandwich generation also may have, they may have a UTI. They may have, their car may have just broke down, or their kid took off, or they've got, the entire family's flying in from Germany and is going to be at their house, and they're trying to figure out how they're going to get it cleaned and ready. And unfortunately, pain robs human beings of having the lens or the optics to see that person as a person versus a service provider. You talked about schedules, you talked about support. Is this part of giving some freedom or support back, or I guess giving humanity back to some of these care providers?
Well, absolutely. I mean, this is all a question of capacity. The nurses and doctors working in the emergencies and hospitals you only go into that profession because you're a caring, compassionate person. And if you're asked to help one chronic pain patient who's having a bad day, and yes, they're going to say some things they don't mean and say it in a tone that they don't mean it in, you can handle that. You can work with that person and be like, hey, it's okay. I understand you're in pain. Let's work through this together. But when you do that over and over and over and over again, or if you can't do it over and over again, you have to ignore like 5 or 6 people. Guess what? These 5 or 6 people in the hallways in our merges are starting to get grumpy. Then they're starting to yell, "Hey nurse, hey doc, what's going on over here?" To put it politely. It's quite a conflict-ridden place, and some of those things that are said, I can't even say on this podcast. So you start throwing that stuff at it, and then you get into a vicious cycle. Then the compassionate person is not as compassionate anymore, and the less compassionate person is provoking the person who's in pain, and there's this back and forth. And that's, sadly, that's an everyday scene in the ER, and that's why it's so important for us to get the patients home who don't need to be there, so that we can relieve the burden from these overworked healthcare workers.
I think there's legacy opportunity that is missed because we're not as involved with our aging parents or somebody who does have some sort of mark on their time, right? Mm-hmm. And I think that sometimes we're so bogged down in trying to navigate that we don't take a moment to truly celebrate those opportunities, those last moments, or those memories that could be created. In working to create a more humane experience, no matter where somebody is within their life cycle. What are some of the biggest challenges in developing this, right? I know that right here, just even getting the conversation going, I think is one challenge, because we've done sick care for so long that now we have to come back and truly look at this and create healthcare, a health space for providers and recipients. What are some of the biggest challenges that you're facing right now? And what can we do to help support you?
Well, you're already doing it by giving us a little bit of a platform to share our product. There is a huge institutional, if not a professional bias in my field as in medicine and healthcare in general, that funnels patients down this pathway towards facilities. Mom can't walk, therefore she has to come into hospital. Actually, that's not totally true. Mom can't walk, therefore she needs help getting to the bathroom, but the hospital is not the only solution. Or mom's in hospital, she still can't walk. The only solution is to become an ALC patient and then long-term care patient and so forth. So we're trying to fight this bias and this automatic assumption that's become ingrained. It's almost part of our DNA.
Yes.
And by the way, it's not just healthcare providers, it's also families, often children, but also patients themselves that think that, okay, once I've reached a certain stage of life, the only logical solution is to go to a facility.
Yes.
Not true. Actually, almost always not true. We can provide that type of care at home. We're doing it right now. And we need to listen to our parents who are sometimes saying things like, and I'm not being facetious here, because I've heard it so many times, hundreds of times, "I would rather die than go to a facility like that." They're talking about long-term care centers or nursing homes. "I would rather die than go to a nursing home." And people hear that, they're like, grandpa. But we need to put ourselves in their shoes and sometimes go to these places to help ourselves understand what they mean by that. And what they mean by that is that they would literally rather die in their own home. I know it's kind of scary to say and hard to reckon with that. Yeah, dad or grandpa will have to die one day and he wants to die at home. We need to listen to that. And so that's the kind of work we do. We took home a 90-year-old the other day from the hospital who was dying of cancer. At this point, the dying was very much accepted by everyone. He was in a shared room hospital bed, which is not much bigger than this room that we're in. 2 patients, 2 families. I'm talking to one family here, fully within earshot of the next family, about dying. That's the amount of dignity you get in hospital these days. We took him home. He had this, upsurge, which everyone does when they come home, more energy, planned his own funeral at home for 2 or 3 weeks, met every person in his family, spent one-to-one time with them in his own home, in the privacy of his own home. And then we provided him palliative care in his own bed, and he passed away in the bed that he slept in for the last 40 or 50 years, surrounded by his wife, his kids, and grandkids. And it was a very sad moment when he passed, but not a single person cried because that grieving process was managed over the course of a few days to weeks. And his wife came to me the next day and said, "Thank you, Dr. Wong. That was a perfect death." And so that's what it means to I would rather die than go to a place like that. That's the alternative. It's a peaceful and controlled passing, which is one of the most beautiful things that we can give our families if you think about it.
I 100% agree. I mean, it's what separates, it's what makes us humane. And I think that in this world, we all talk about being human, but if we just put an E on the end and take that little extra time and, effort, we can be so much more. You had mentioned that the MD services are covered by, it can be covered by Alberta Health. So instead of $67 a day at the hospital, and these are not quotable numbers. Please do research. Please reach out to Dr. Wong, versus 50% less for that cost. What are some other details, some other understanding of how people need to navigate this system?
Great question. So everyone thinks or wonders whether at-home care is out of reach for them because they're not multimillionaires or billionaires. And it's not. At HomeFree Homecare, our large majority of clients are perfectly middle-class Canadians that have prepared for their retirement. And our system, and I'm pointing at a card right now that we have that shows how we access public funding support that covers the vast majority of our care. It's called CDHCI. So if you don't remember anything other than this acronym CDHCI, which stands for Client Directed Home Care Invoicing, this is the Alberta Health Services public funding program that every single Albertan has access to. When you call the regular home care line, you will be offered traditional home care services. So if let's say you're calling on behalf of your mom needs help at home, she can't cook, she can't use the washroom, home care will offer you someone who will come and microwave a meal for her and bring her to the bathroom. There are a lot of limitations to that, which we've talked about before. But if you wanted to direct the resources that would otherwise be given to her towards a private provider, you can switch the funding from traditional home care to CDHCI, which means that your mother will be qualified for a certain number of hours per week of services, which is essentially a dollar amount that you can apply to a private provider, of which we are one of many. And then you have to be a qualified provider to deliver this care, of course. But then the nice thing about this is that the providers, like us, compete on product. So you get to, as a daughter or a family member or as the patient, decide what works for you, which home care company is going to best serve your needs, and then you can apply your public funding to that program, and they'll come to your home and take care of you. Some programs, like ours, offer a premium service and will charge a bit of a top-up. The top-up enables us to pay our workers a living wage and to provide some extra benefits and services and make sure we're doing an amazing job. Not every provider does that. There's a spectrum of services that are out there, and we would consider ourselves on the kind of premium end. But just to give you an idea of numbers, our top-up is in the range of $10 an hour, which means that if you're getting what I'd consider a fairly large volume of services, which is our average client, because we're pulling patients that would otherwise be in long-term care centers or in hospitals and putting them back home. A large volume of service is 4 hours a day, 4 to 8 hours a day. So if you're getting 4 hours a day, that's, call it 28 hours per week, that would be $280 per week out of pocket, which is about half of your $70 a day, which is about $500 a week that you'd be paying in hospital.
Wow.
So affordable, I think, to say the least. And yes, there are people that pay more for more services, but you don't have to. You acquire the volume of services that you require. And it could be less. It could be just 10 hours a week or even 5 hours a week. So it just depends on your personal needs.
Amazing. And I had never heard of this at all. And I think that there's just sometimes where there's more opportunities than than people are talking about. And that's why it's so important having you here and actually talking that there are alternatives, right? Because we're at the business club, I do want to ask business clubs or business leaders and innovators, how can they support, scale, or even incorporate support for programs like this within their policies or within their services or anything like that? Does that make sense? I know we have benefits packages out there.
Right.
And I think that we have a lot of people who, like you said, Gen Xers that are now caring for their parents. And this is going to be big over the next 15 years.
Huge.
How do we rethink benefits and support so that we can do more things like this to give our parents back that dignity or that comfort in their final years?
That's an amazing question, because most of the clients that we work with are the children of the seniors acquiring our services. That means that these are usually very busy professionals. They're business people, doctors, teachers, podcast hosts, and they have a working life. And when they have to look after a parent, it comes at a huge cost to them personally, but also to their business and to the work that they're doing. So it's in the business and the employer's interest to actually enable their workers to look after their parents in a professional way. So I would say, and we've seen this from a few private insurance programs, is have some sort of top-up contingency for your employees to pay for their parents' home care. So maybe this could be a health spending fund. This could also be just written in to like nursing services. So a lot of private insurances will have some sort of program where if you hire private nursing services, it will pay for a certain amount per week or per month. Make it such that it can be eligible for a family member. So that number one, for a family member, and number two, make it extended to HCAs, healthcare aides or non-nurses. So a lot of times these insurance programs will actually restrict the care to a higher cost provider, which is a registered nurse or an LPN. Whereas actually the large majority of services that elderly people require are provided by a lower level of healthcare provider called an HCA, which comes at half the cost. So we're sometimes having to utilize a much higher cost service to match the insurance program. Whereas if the insurance program had actually allowed us to use the lower cost provider, it would have saved everyone a lot of money and been just as good for the patient and family.
Wow. There's a lot to kind of unpack and review to get us prepared. We're literally just at we're not even at the peak of the baby boomer era. And so there's a lot that's going to be going on, and it'd be better to get it dealt with now than, 5 years or 10 years from now, right? Get ahead of it. Let's talk community. So here at the CPC, we really talk a lot about community, and this is something that seems to be a core. And I know that you've touched on how you care for your providers, so they in turn can care for your clients or the people that you're working on behalf. So what does it mean to you, both as a physician and a leader working to develop a new way of thinking, a new service? What does community mean to you?
Okay, that's a great question. Well, I'll answer it with an example of how we operate as a home care provider. So the community that surrounds a patient, let's use someone's mom, for example, is usually the whole support system of that individual. So a very typical scenario would be an elderly mom, perhaps in her late 80s or 90s, who actually has 3 or 4 kids and their spouses all chipping in. Sometimes, the one daughter comes on Monday to help, the other one visits every other weekend, the other one helps with doctor's appointments. There's a huge mishmash of things. So what we do as a company is that, knowing this, we actually force the whole family to sit down with us, our team, once at the beginning of the relationship, before they've signed any contracts with us, just so we can get to know them. But it's not enough for us to meet just the patient or just the daughter. We have to meet the whole family, and something really beautiful happens. I mean, I've been speaking with patients, usually one daughter and one family member at a bedside for a decade in hospital. But when I started doing these family meetings where we have like 4 kids, spouses, the patients in their own home, where we can like point to things like, remember when that happened, or remember that, something crazy happens. It's like fireworks. There's just stuff coming from every direction, stuff totally unexpected. There's wows, there's surprises, there's emotions. And essentially it's like a big therapy session. We're asking the daughters to point out, well, what's been going on with mom or dad? And they're going to say stuff that they've never said before in front of their parents because they were too scared to offend them or to make it seem like they've been a burden to them. But within the facilitated environment, they're able to let these things out, and with our encouragement. And same thing on the other side. Moms and dads in their 80s or 90s will say stuff with us present that they've never said to their kids before for years, because they didn't want to seem like a burden also, and they didn't want their kids to think this or that about them. And so when we have that ability to open up as a community and to actually say what we need to say, to put everything out there in the open, then beautiful things happen. Solutions can happen. And at the end of all that, our hope, and usually is the case, that everybody's life gets better. It's not just about the parents. It's also about the children, the families who've been burning out looking after their parents. And so it's a win for everyone, we think.
Community. Food, shelter, education, medication, medical support. At the end of the day, these are the only things that truly matter.
That truly matter, absolutely.
You can find all of Dr. Charles Wong's information, HomeFree Homecare, in the show notes. And, find a community. Lean in. Thank you.
Thank you for joining us today on the Back to Business podcast. Be sure to visit calpeteclub.com, CALPETECLUB.com, to find out more about upcoming events, networking opportunities, and membership. If you are not already a valued member at the CPC, where we are proudly connecting and supporting Calgary's business leaders.